Good afternoon or good morning, depending on where you are today. Welcome to today's webinar. The webinar is Inpatient Care Experiences Matter Most to Patients, Valuing Items from Canadian Patient Experience Survey. Before we begin today, I'd like to go through a few housekeeping items. As usual, we'll have our Q&A session at the end, and hopefully we will get to all the questions, and if we not, both presenters today have their emails at the end of this presentation, and you can forward your questions to them directly. Please submit your questions during the online presentation, and that will allow us to ensure that similar questions are put together and we get to as many as possible. As a reminder, we have a pop-up screen after the webinar, and for this we're hoping to get your feedback on both how to improve the webinar series and if you want to send some comments to the presenters today. And the webinar slides and the video will be available within 48 hours, and you can see the URL on the screen. In the next month, we have some upcoming webinars that I hope everyone will register for. On January 10th, we will have identifying older patients at high risk of poor outcomes after joint replacement surgery. On Wednesday, January 24th, we'll be hosting a webinar on reducing post-discharge potentially inappropriate medications amongst the elderly and multi-center electronic deprescribing intervention. And on February 14th, we'll have an ounce of prevention intensive resistance training to optimize health in pre-frail older adults. So just to give you an update, our 2017 Catalyst Grant Competition on polypharmacy that we're hosting with or partnering with New Brunswick Health Research Foundation and the Canadian Institute of Health Research is now closed. They are now, all applications are in the review process, and the expectation is that they will be announced sometime in the spring. There are new funding opportunities coming up. One is the competition based on the results of the Canadian Frailty Priority Setting Partnership, which will be launched likely in the next week. So please look for it up on our website, and we will be distributing email widely and tweeting and using every form of communication to get that out so that everyone can participate in that competition. We are also doing new funding opportunities for our HQPs. There's the 2018 Interdisciplinary Fellowship, and it's a one-year fellowship, and that will be coming out in the next week, as well as the Summer Student Awards Program. Both of those competitions will be on our website shortly, and the details will be communicated widely as well. So for today, I want to introduce you to two individuals who are going to be presenting today, both in probably sunny BC as opposed to wintry Ontario. So we have Nick Bansbach, who's the Associate Professor in the School of Population and Public Health at the University of BC. His research includes different methods of decision analysis to improve health. His methodological area of research include measuring and valuing health, economic evaluation, and network meta-analysis. Also joining us today for a presentation is Logan Treneman. He's a PhD candidate in the School of Population and Public Health at the University of BC, and his PhD thesis focuses on understanding of how patients value different aspects of healthcare delivery and outcomes. So over to you. I think, Nick, you're starting today.
That's right. Let me... Okay. Welcome, everybody. Hopefully you can all see my screen. We're going to... I'm going to start off this morning and then going to hand over to Logan to talk about the methods and the results of this project. But I'm just going to start, this is the outline of our session today. And I'm going to start by thinking about the word value, because we use this word value to mean many different things. Sometimes we use this word to think about our beliefs or about sort of like a numerical value in that term. But Logan and I come at this term value from a sort of economics perspective. And if you have done any economics, you'll learn about consumer theory, that people actually make choices based on the value that they assign to different attributes of their options. And so if you think about value, there's some key sort of aspects of it that we're going to sort of is key for us to understand. And the first one is that to understand how much you value something, you can only do that in comparison to something else. The value of a car is only understandable if you compare what a different car or a different way that you can, different good that you might buy. And the actual amount of value that you place on a car is the amount of money, in that case, that you would be willing to pay for it. And so the value of something from an economics perspective is determined through a comparison and a trade-off. A trade-off in that sense about how much I'd be willing to pay for a car, but it doesn't have to be just money. You can think of value from anything that you're willing to trade off against. So I can determine the value of something by how long I'm willing to wait for it, or my willingness to accept something else, such as maybe a side effect might determine the value of a treatment for me. And I think this idea of value from sort of consumer theory is the value that we're thinking about when people talk about high value care, value-centered care. It's this quote here from Porter talking about achieving high value for patients must be the overarching goal of healthcare delivery. Because this is the type of value that actually reflects people's choices, actually reflects what they consider important to them. So that's the first aspect of value. The second aspect is that, well, what I might value may be very, very different to what you value. And that's okay. We have different tastes, and I might think that one car or one feature of a car is really important to me, and it may not be to you. And so this idea that value can change between people is just accepted. But what is interesting is that actually it can often be quite predictable about certain people will value, certain groups of people will value things differently to others. It's not always hugely predictable, but there's some correlation. So value can vary between people. And then the last thing on value is that actually what you value can change. It's not hard-coded. It's not something that can be defined from a blood test. But it's something actually that can change over time and often will change with your experience. So, for example, often we talk about the fear of the unknown. The good example is injections. People often who've never experienced injection will value that very importantly, saying, I'm not sure I want this treatment with an injection. But actually, after they have used injections for a time, some people will then say, actually, that's not that important anymore to my choice. And so as we experience things, our values can change. So that's the background to value. I'm now going to move on to sort of what we're interested in valuing, and that is actually the healthcare experience, or specifically experiences of inpatient care. And patient experience is something I think has been recognized as really important for our healthcare system for a number of years, but more recently there's been some much more strategic initiatives about measuring it. And so the Canadian Institute for Health Information has developed the Canadian Patient Experiences Survey for Inpatient Care. And this is a survey, it's actually more formally a PREM, or Patient Reported Experience Measure, which aims to document and improve patient care across Canada. So it's quite a large instrument. It includes 49 questions, spanning from when somebody is admitted to their hospital to when they're discharged, and all sorts of things in between. And it's currently being collected in, I believe, over 20,000 responses from individuals who've experienced inpatient care, have reported their results to CPES-IC. I think there's actually far more than that have reported their results. And this is ongoing in a number of provinces across Canada. And so if you see here some examples of what types of experiences that are being measured. And so this top one is asking about communication with nurses. So these are just 3 of those 49 questions. And so I think this is going to be an incredibly valuable resource for us to understand what is happening in hospitals, how is this varying between provinces and hospitals, and I'm really looking forward to looking into some of the results. The thing that we're thinking about from this perspective is how these results can be enhanced. So if I try and sort of tease back the idea of value to this instrument, this is asking people to report their experiences on this scale of sort of always to never. And it might then be tempting to look at the experiences which a hospital is doing poorly at. No hospital, I expect, was going to score great high marks with every single one of these 49 items. And so it's temptation to look at the one item which is perhaps doing the worst for a given hospital. But what we would want to start thinking about is, well, actually, are each of those experiences equal? Or actually, do some matter more than others? And how do we even go about answering that question? And that's where the idea of value and the value of each of those specific experiences compared to each other comes in. So we would like to understand which of those experiences are most and least important, and we'll explain at the end about how those results could then be used to make decisions in terms of improving hospital care. So our objectives are, for this particular presentation, the project that it was based on was the values of patient experience defined by this experience survey, this PREM, in Canadians over 60 who have recently been hospitalized. Our broader objective is to sort of look at this heterogeneity, this idea that values will differ between different groups. And what we would be very keen on is trying to understand whether values vary in different groups. And one of those groups that we think would be incredibly important to understand is the frail individuals. And so that's one of our goals of our broader project. As you'll see from Logan, as we talk about how this project went, we were limited for this sort of catalyst project to look at-risk individuals. So not necessarily the group that we were initially wanting to focus on, but hopefully our experience is going to let us understand how we could do that in a further project. So with that, I'm going to hand over to Logan to tell you about what we did.
you very much, Nick. Hi, everyone. My name is Logan. I'm a PhD student at the School of Population Public Health here at UBC. I'm just going to pick up where Nick left off, walk through some of the methods we used in this project, the results, discuss kind of the implications and how we could potentially use this moving forward, and also discuss some potential avenues for future research. But as Nick mentioned, value really comes down to trade-offs. And one of the real challenges is that trade-off tasks can be very challenging. So it's asking people to make often very difficult trade-offs. And from a researcher's perspective, that can be a good thing because a difficult trade-off actually can provide a lot of information. One of the challenges we have in measuring value is that these trade-off tasks can be very cognitively challenging. And so in considering which technique we were going to use to actually value these patient experiences, we considered a number of different techniques. And we settled on one that's called best-worst scaling. And one of the reasons we went with best-worst scaling is because it's considered one of the least cognitively burdensome tasks. I'm going to give an example in a second of what best-worst scaling looks like in sort of its simplest form. But basically, it'll present respondents with 3 or more items that you want to value. In this case, we're going to present the different experiences from the Canadian Patient Experience Survey. Respondents are then asked to pick which of the 3 items they view as the best and which of the 3 items they view as the worst. And it doesn't necessarily have to be best and worst. It can be most important and least important. But the idea is you're asking people to make a distinction and choose one for each of those categories. You'll ask respondents to complete a number of different questions. And across the experimental design, all of the items that you're trying to value are compared an equal number of times, and so you can get an idea of how they're valued indirectly. And this can provide both a rank order of items, so you know which item is considered most least important, but also a relative value, so you can make a distinction between items and say, well, this item was valued twice as much as this item. And so one classic example of best-worst scaling was aiming to value different varietals of wine. So for instance, this would present 3 different varietals of wine, a Cab Sauvignon, a Chardonnay, and a Rosé, and it would ask respondents, now which of those do you think is the best and which of those do you think is the worst? So a respondent would pick one and the other. And I think it's worthwhile comparing to how this might differ for something like a Likert question. So I could very legitimately say, I really like Cab Sauvignon, I really like Chardonnay, and I really like Rosé. But in this case, I'm being asked actually to pick, well, which one do you prefer and which one do you actually think is the worst? And so it's forcing that trade-off, which provides different information. And as respondents would go through a best-worst scaling survey, they would complete another question. This might ask 3 different varieties of wine, and again, they're asked to pick a best and a worst option. And by completing a number of these questions, aggregating it across individuals and a sample, you can get an idea of, in this case, how much each of these varieties is actually valued. And so we weren't aiming to value varieties of wine, we were aiming to value the experiences from the Canadian Patient Experience Survey. Nick mentioned off the top that there's 49 different items that are included on there. Not all of these are considered experiences per se. So for instance, there are several demographic questions. There's also 4 items related to overall rating. So this asks people how much they were helped on a scale of 1 to 10 from their hospitalization, overall satisfaction ratings with the hospital. And so we were really interested in the components of experience, not these overall rankings per se. There are also a variety of yes/no questions about whether these certain experiences happened or not. And so we excluded these items as well. So in total, this resulted in 25 experiences to value, which is still quite a few. So we had to keep that in mind as we were considering the different techniques and ways we would actually go about collecting this. But just to give some perspective on the different experiences that are covered in the measure, we drew experiences to value from 5 different categories. And you saw one of these earlier in a slide that Nick talked to. But the first category relates to care from nurses, and so there was 4 items that fell in this category. So for instance, one asked, how often did nurses treat you with courtesy and respect? Second category related to care from doctors, and there was 3 items here. These items all mimic the items found in the care from nurses. So for instance, how often did doctors listen carefully to you? There were 8 items related to the hospital environment, and so this asks things like how often the area around your room was quiet at night, how often your room and bathroom were kept clean. There are also 7 items related to what actually happened during the hospital stay. And so a lot of these items related to care coordination, communication. So for instance, how often were the nurses and other hospital staff seem informed and up to date about your hospital care. And then lastly, there was 3 items related to actually leaving the hospital. So did you have a better understanding of your condition than when you entered? And so this just provides some perspective on kind of the breadth of experiences that are included in the measure. So as we were going through this, we came up with a draft survey. And so we came up with a number of different items that we wanted to cover. And one of the items we wanted to cover, as Nick mentioned, we were looking at people who had actually recently been hospitalized. And so one thing we were really interested in is, what did that previous hospitalization look like? What was their experience? Because that might be something that influences values and that we'd like to look at later. And so we had people complete the Canadian Patient Experience Survey based on their most recent hospitalization. We also thought this would be a nice kind of warm-up exercise. It would get people familiar with the items before actually completing the best-worst scaling task. For the best-worst scaling task, we actually changed the experiences from questions as they're used on the survey to statements. So for instance, how often did doctors treat you with courtesy and respect became doctors treat you with courtesy and respect. And I'll show an example of our best-worst scaling questions later that I think will illustrate this. We also asked a few health and demographic questions, and then the Prism 7 questionnaire. And we used this questionnaire to actually identify individuals that were considered at risk of frailty. And so for those that aren't familiar, it is a 7-item questionnaire. All are yes/no questions, and 3 or more yeses indicates that an individual is at risk for frailty. So here's an example of the best-worst scaling task. So we asked participants to please imagine that you need to be hospitalized in the near future, and which of the following would be most important to you, and which of the following would be least important. And they were asked to pick 1 on each of them. So in this case, they're comparing things around pain control to how they're treated by doctors, they're treated by nurses, how involved their friends and family are in decision making. So they'd be asked to complete and pick 1 most important item and 1 least important item. So we started off with this draft survey, and we went and did some pilot testing. So we did 10 in-person interviews with individuals aged 72 to 93. And there's a few things we were trying to get out of these interviews. First of all was testing comprehension. Was there anything that didn't make sense? Any of the instructions, the task itself. But we also wanted to get an idea of mode of administration. So as was mentioned at the beginning, the Canadian Patient Experience Survey is actually administered by phone. It's done by mail, or individuals can complete it online. And so we, as interviewers, mimicked, say, a phone administration of a best-worst scaling task to get an idea of how that would go. That was very challenging for participants, as you can imagine. Having to keep 3 or more items in their head at one time and pick the best item and a worst item was quite challenging. We also did kind of an interviewer-administered kind of in-person version. Participants really liked this, but it did take quite a bit of time, between kind of 45 and 90 minutes to complete the survey. So we also considered kind of online administration. So if we just gave the survey to patients or individuals, how was it to go through? As we mentioned at the beginning, we're trying to value 25 items, so we have to consider sample size. And so we decided to test it in an online panel of approximately 100 respondents, just to get an idea of whether the survey would work in this format, but also to get an idea of kind of which kind of respondents we would get. Would we get a population of individuals that are deemed at risk for frailty based on the measure? So this administration went well. We did get a proportion of patients who were defined as at risk for frailty. And so we settled on a final design that presented 5 of these different experiences in each question, which required we asked 30 total questions. We didn't want individuals to have to complete 30 questions. That's quite a long survey. So we actually blocked it into 3 versions with 10 questions. So each individual completed 10 best-worst scaling questions. We then went to an online panel of Canadians who were age 16 older, who had been hospitalized in the past 5 years, and we did the analysis using a conditional logit model. So just to provide a bit of overview of our sample, we had over 1,000 respondents, And as you can see there, most respondents were between the ages of 60 and 75. A fairly even gender split and quite a highly educated sample, with over half of respondents having some kind of postgraduate training. In terms of their most recent hospitalization, about a third had been hospitalized in the last year, but we did have a number of people who had been hospitalized between 2 and 5 years ago, almost half. Kind of an even split between whether it was a scheduled or emergency hospitalization. And the Prism score there at the bottom, our mean was 2.5. So if you recall, a score of 3 or more is considered at risk for frailty. So about 45% of our sample was deemed at risk for frailty based on the Prism 7. So I'm just going to move into the results. We have here listed all 25 of the different experiences. I'll pull them up kind of section by section. But on the right, those bars indicate the relative value of each of these experiences, going from most valuable at the top to least valuable at the bottom. Like I said, these can be interpreted as relative values, so a bar that's half as big would be half as valued as the one at the top. So starting with care from nurses, we found these items fell sort of towards the middle, so nurses listening careful to you, treating you with courtesy, respect, and explaining things in a way you can understand. This can be contrasted with care from doctors. So the care from doctors, which have very similar items, all 3 of those items we found came out in the top 10. And if we look at the hospital environment, a couple of the items that came out as most important from this category related to pain. So for instance, your pain is well controlled and staff do everything they can to help you with your pain. But perhaps equally surprising is what comes out near the bottom. So your room and bathroom are kept clean, and the area around your room is quiet at night, were 2 of these items that people ranked as the least valuable. Then move on to what actually happened during the stay. So the most important item to individuals was staff seem informed and up to date about your hospital care, and there's sort of a theme there in the top items around care coordination and being informed, communication. Also being as involved in decisions as you wanted to be came out near the top, but again, contrast that with item number 24, which related to how involved friends or family were actually in decisions about their care. So that was something that wasn't as valuable. And then the last 3 items relate to actually leaving the hospital, so having a clear understanding of all your prescribed medications, and getting information on what to do if you're worried after discharge. So these were kind of spread throughout the middle. So that just provides some perspective on how our overall sample actually looked. But one thing we were really interested in, obviously, was whether these values would change depending on when individuals were at risk of frailty. And so if you look here, you see that we've categorized them again at risk for frailty, scoring a 3 or greater on the Prism questionnaire compared to those that are deemed not at risk. The rank order changes a little bit, but I thought I would pull out, it's quite hard to see with these bars, I thought I'd pull out the 3 items that actually changed the most. And so these 3 items are the ones that were deemed more valuable to individuals at risk of frailty. So for instance, your pain is well controlled and staff do everything they can to help you with your pain. So these 2 items were the 2 that actually moved up the most in terms of value for individuals that were at risk. But also family and friends are as involved in decisions about your care. And so from some of our interviews, this was one item that we noticed talking to people, was that often they were they really valued having friends or family involved in decisions when they were making them in health. So I'll move on now to some discussion points. This was really meant as kind of a proof of concept study for us to get an idea of how we would go about doing this valuation task, and I think it can demonstrate why such a larger project might be of value, how we can start to get an idea of the relative value of these different experiences, provide some insight into which experiences might be most valuable to patients. One thing we were interested in, I mentioned off the top that there are some overall ranking questions that appear in the Canadian Patient Experience Survey, and I know there's been some work done looking at the correlation between the experiences and those overall ranking questions to get an idea of how much things are valued. So we've done a bit of preliminary work comparing the values that we got from the best worst scaling task against correlation with overall ranking. And this preliminary work seems to suggest that we get some different ranks. And so this is something that we're going to continue looking at moving forward. But I think Nick outlined at the beginning how we thought information on value might be able to complement the ongoing data collection. So I think what we have right now from the Canadian Patient Experience Survey is we can identify some items and individual experiences that are doing quite well, whether it's at the overall level, at individual hospital level. And we can also identify those experiences where there maybe is a room for improvement. But what we're really hoping for is that this information on value can help to provide a different dimension and start to tease out not only those experiences and how well they're performing, but also, well, which experiences are maybe the most highly valued and which ones are of lesser value to patients. And what this might allow us to do is to say, okay, if we're going to focus improvement efforts, we should probably focus on those items that are both performing poorly, but also that are the most highly valued by individuals. I think we need to acknowledge some of our limitations. We went to an online sample, and this was done to achieve the required sample size. However, we recognize that this doesn't truly reflect the values of individuals with more severe frailty. I mentioned that we did collect the Canadian Patient Experience Survey from individuals, so we have an idea of what their past experience actually looked like in hospital, but we have not yet accounted for how that experience might influence the value. And so I think it's logical to expect that if people had a very bad experience on one of those items, that maybe that's something that they would report as being more valuable. So we're still working through how we can actually account for this moving forward. Also mentioned that these are respondents who had been hospitalized within the past 5 years, and there was quite a few who had been hospitalized between 2 and 5 years ago. And so ideally, we would have had participants who had just recently been hospitalized. But so there might be some recall bias there when it comes to some of the responses. And thinking about how we plan on moving forward and ideas for future research, I think one of the logical ones is to look at the responses that we had in our survey from the Canadian Patient Experience Survey and compare our responses with data from CPES-IC. And I think this will provide some perspective on how representative our sample actually was. So did our sample have kind of comparable experiences to what we see in the CPES-IC data, or is there a significant difference? Obviously working on accounting for past experiences, but also starting to explore some of the heterogeneity in responses. And so there may be subgroups of individuals that have very distinct preferences. So potentially doing some modeling techniques like latent class analysis to tease out that and start to see if there are those subgroups of preferences within there. But also potentially capturing these subgroups of responses where we expect that the values really may differ. And so thinking about ways of moving forward of capturing these groups of individuals that might have different preferences and how we might have to go about using different techniques, whether it's in-person interviews, et cetera, to actually get those responses. So with that, I just want to acknowledge the funding that we received from the Canadian Frailty Network for this Catalyst grant. The other study team members, so Don Stacey, based at the University of Ottawa, Lena Cuthbertson, based here at the BC Ministry of Health, Sterling Bryan at UBC, and Rick Sawatsky, who's based here at Trinity Western. And as we said at the outset, we've got our email addresses up there, so if anyone has any questions, comments that they're not able to get in during the question period, please be in touch, and we'd be happy to answer them. So thank you.
Perhaps before we hand it over for questions, just want to thank Logan for going through there. Just one reflection for me about what would be helpful for us to receive feedback on. As Logan was saying, that this was sort of a proof of concept study to sort of try and show and demonstrate, what can be done and what kind of results could be created and generated for these kind of experiences. And so it'd be really interesting for us to know whether this actually is evidence that is important. Would it actually be helpful to decision makers determining which areas to be focusing on for improvement. If not, how could it be more important? Are there different ways that we could have done this? But I think, as Logan was saying, if we were to do this project sort of more comprehensively, it would be a much larger undertaking with face-to-face interviews with much more representative individuals. It would be quite a large study. So we're just keen right now to sort of find out whether that is a study worth pursuing and whether there are other people who would be interested in collaborating on such a study. So with that, we're happy to answer any questions you might have or answer further questions by email, but we'll hand that back over to you.
Okay, thank you, Nick and Logan, for your excellent presentation today, and our Manager of Research, Perry Kim, will facilitate today's Q&A, so please continue to submit your questions and we'll try to get to them all today. We have quite a few come in already, so Perry, I'll send it over to you.
Hi, Nick. Hi, Logan. Thanks for the talk. It's very interesting. We have a handful of questions that have come in, so I'll just jump right into them. First question is, can you provide a review again of the value score associated with friends and family involved in your care in comparison to the most valuable experiences for those at risk of frailty?
Sorry, so that I think the question is related to an individual, the item around the friends and family being involved in decisions about your care and how that varied based on the risk of frailty or not. So that was one of the 3 items that I highlighted as kind of moving up. And I think in terms of the overall value, it was about double, I think, for the individuals that were considered at risk for frailty. And as I mentioned, as I was going through and kind of reflecting on that, I think that item was one that we were kind of surprised came out towards the bottom if we just looked at the full sample. But from our interviews with individuals, some of whom had a family member with them, it was something that came out as being very important. So I think that was one item that we weren't really surprised to see move up based on that status.
Right, fair enough. Yeah, I was surprised with those results as well. I'm curious if I could follow up. How did you decide on choosing the Prism 7 frailty survey or questionnaire versus other frailty measures?
Yeah, so that was looked at a review from 2013. I'm trying to think of the name of the first author, but it was published in, I believe, Age and Aging. But it looked at 5 different measures to assess frailty. So I think they were all meant to be kind of short screening measures. And that was the one in that review that came out as being that they reported as being the best. So that's kind of why we went down that route.
But I think this is a question that's come up a few times. So I think if we were to do this again, we might reconsider based on the advice we've been given.
Great, thank you. Another question here related to the study itself. It appears that the best, worst scaling does not assess how we've done on each question. So would we still need to include the standard questions assessing how often we met the goal listed in the question?
Yeah, so yeah, we need to be very clear here. What we're doing here is to complement the survey. So you absolutely would need to complete the survey to articulate and report how your experiences were, whether they were good or bad. What we're doing is something separate, which could then, and we're not envisaging that everybody would be doing this. This is something that could just be done in a sample of individuals, just to understand, on average, in certain predictable groups, which of these items are most or least important. So yeah, this is not saying that we're replacing anything. It's a very separate but complementary technique.
Right, fair enough. Just a follow-up question, Nick. In terms of the Canadian Patient Experience Survey that CPES-IC conducts, which I think you were referring to do they assess frailty, or is it possible to tease out that information from the information they collect and then sort of relate that back to their answers?
It's a great question, and I wish one of our collaborators was here to answer it. We don't think so, but we're not totally sure. So we could perhaps get back to you on that.
I know that there are the 8 demographic questions that come at the end, but from my recollection, no, there's not one of those that corresponds to frailty. So it would need to be captured somewhere else in the data collection, but I'm not sure if that's the case.
Great, thank you. Maybe if someone's online that's from CAI, they could send in the response in the question panel. We have another question, sort of a process question. How did you recruit the 1,000 or so patients, the online sample?
So we went to a market research panel that got us basically a sample of Canadians, so all across Canada, that was roughly representative within kind of the parameters we set, which was 60 and older. So that was kind of the rough overview.
So these, just to explain, people may be unfamiliar, but these market research panels are developed and then used by a wide variety of mostly companies to determine, sort of get feedback on their products or all sorts of things. And so they spend a lot of time trying to get members to participate in their panels who are kind of represent key demographic groups. But obviously the panel that we used were able to use a computer and the internet. So from that point of view, as soon as we went down that road, we knew that we were going to be excluding probably the people that we really would be interested in including. So that's why we had this sort of switch, and why we would, if we had larger budget, definitely kind of be moving to a sort of in-person interview. But yeah, these panels you can basically be quite specific about who you would like to participate with, based on different demographics and even characteristics such as whether they've been hospitalized or not.
Right. So in terms of the online survey itself, was it a survey in terms of sort of a website that one would pull up, or was it more of an interactive online sort of interview like you might do with Skype or even GoToMeeting and so forth?
No, it was much more of a conventional sort of survey, and so there was opportunity for people to provide comments if they got confused or weren't sure what to do, but it was a fairly conventional survey that they were sent to in a link.
Oh, okay, thank you. In terms of sort of related to your answer, we have a question here with respect to filling out such surveys, or sort of gleaning the preferences of priorities if the older adult is experiencing or is dealing with dementia, cognitive impairment. How would you deal with or sort of tease out their priorities or preferences in those sorts of patients?
Yeah, so I think that gets to the root of sort of our interest, if we're honest, because we feel like, and even what we've done in this study kind of falls into this trap, but we often hear and get information and evidence and values from groups of our population who are more easily able to articulate and be contacted to provide those, and it can be more challenging to be getting responses and values from individuals with dementia, etc. But that doesn't mean that their values are not important. And so I think that speaks to the heart of what we'd like to do. We really want to be getting and understanding values from everybody, so that the decisions on how we organize our inpatient care do reflect everybody's values and preferences. So I think that's why we spent quite a bit of time on this project, and what's been really useful and learning process for us is just to sort of think through how can we ask questions that are cognitively challenging and how do they work. And we actually felt like even though the first time people answer this question, it can still be quite difficult. They often take quite a long time answering the first question. People warm up to it fairly quickly. So even in our 10 individuals that we did the face-to-face sort of interviews with, some of which were very challenging cognitive difficulties, they were actually able, with some support, after completing one or two, able to complete these questions in what seemingly was a sort of sensible way. So I think we feel like we've found the approach that we could be using. It's just finding the people now to answer those questions in large enough numbers.
We have a question here, Nick. Does the best-worst scaling lead to respondents not answering the question due to the inability to choose only one best and one worst item?
Yeah, it's a good question. Like, so I can't choose. These two are equal.
Right.
And so where do I go? You know, often this actually is the point, though. This is where you get at it. If you make questions really easy for people to say that something's equal, they will say it's equal, and because they won't be forced to actually make that difficult trade-off. And so we actually find people get that, and it's harder, but that's exactly what we're trying to get at. Like, if you look at these 25 items, they're all important. Like, I want all of them. And so if I asked 25 Likert style questions of, are these important to me? I think I would say they're all important. I want them all. And so, of course, we want them all. And wouldn't our healthcare system be great if we had all of them? And so what we're trying to get at is it's harder when you actually force a trade-off with, well, okay, if I can't have them all, which one am I going to prioritize? And that's what picking the one forces people to do. And we don't see much dropout. I think we've reported that we actually didn't have hardly any dropout for people during the actual questions. So I think actually just engaging the task kind of forces people to sort of start thinking in that way.
So Nick, when you said dropout, do you mean individuals that actually abandoned the survey?
Yeah, so people didn't abandon the survey. I think we had maybe one or two out of our 1,000. So it didn't seem to be a reason for people to stop.
Oh, that's great. Looking at your results, I was thinking the same thing. It'd be nice to have it all. I'm curious in terms of when people chose the priorities. I think you mentioned this, but I may have missed it. In terms of the patient past experiences and their actual experience in the hospital, did that have an effect on how they ranked certain priorities?
Yeah, it's the question Logan and I talk about. Like, we hypothesize yes, but we can't quite tell you right now by how much.
Right.
It's quite difficult to actually analyze that. And even with our numbers, like the models, the statistical models to try and account for that are a little bit tricky. But we think we would be surprised if they didn't. And so I think that's something we need to sort of tackle, because we don't, in a sense, that would, if we're using the results in the way that we're sort of articulating could be used, that could, in a sense, confound or bias your results. And so what we'd like to be able to do is sort of remove that effect. I think it'd be interesting to see the effect, but then we'd like to remove it so that these values are now kind of irrespective of people's experiences. so that you could then guide sort of more broader decisions about changing your hospital care. So that one is work in progress. I'm looking at Logan, and you know, he's got to finish his PhD, so this is going to be one of his tasks to think about.
That's great. Yeah, I was just thinking that sometimes we take for granted the good things that we experience, and therefore we wouldn't rank them highly unless, for instance, you know, your hospital stay, you just didn't have a quiet room, and that would sort of percolate up to the top of your priority list at some point then. Sort of related to this string of thought, we have a question here asking, could it be that some experiences are not mutually exclusive? So for instance, a respondent would value involvement in care as the most important, having in mind that it necessarily implies that she or he is listened to by the doctor or nurse.
Yeah, no, I think if we looked at kind of sort of the groupings, so we had some natural groupings in the data, for instance, care from nurses, which talks about being listened to, treated with courtesy and respect. The ones from doctors, they seem to group in different areas, but certainly that there might be correlation between the individual items and assumptions that having one means necessarily that you've got the other. So I think that is something that might be there.
Okay. Okay, so thank you again. I think we're near the end of the time. I think we have one or two questions that may have not been answered, and so you might hear from those individuals today. And I believe your email is on the screen, so our audience can look at that and maybe forward them to you. I would like to give you an opportunity today, before we sign off, on any final thoughts or next steps that you'd like to share with the audience.
Well, you know, those questions were just great for us because it shows some of the challenges in this, and so again, I just want to thank you and reiterate that we'd like to sort of know, is this something that we should be moving forward, and if so, how could it be done in the most effective way? And very keen to hear from you. So thank you very much, and we'll sign off. Okay.
And to your point, I think there are some opportunities coming up in the next 6 months to a year on projects that are in the pipeline that are completed that would go to a KT-like project. So watch for that in the next while, and any of the audience that are interested could contact you as well. So I appreciate you both presenting today, and I thank the audience for submitting some good questions today, as usual, and hope all of you can join us for our next webinar on January 10th, which you can register for right now if you want. And basically the screen will have something pop up, and hope that you can complete that. It will only take a couple of minutes to help us out and give some feedback to the presenters today. And hope everyone has a really good rest of the day, and bye for now.